Welcome to our webinar titled Pediatric PNH, Diagnosis and Treatment. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion by using the call-in number in your reminder email. Today's program is being recorded and will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Our specialist today is Dr. Satheesh Chonat. Dr. Chonat is a pediatric hematologist-oncologist at Children's Healthcare of Atlanta and an associate professor at Emory University School of Medicine. He specializes in the care of children and young adults with non-malignant rare blood disorders by using a variety of clinical and research-based tools. He is the site investigator for various clinical and translational research projects focusing on rare blood disorders. The main focus of his laboratory research is to understand the role of complement and immune protein in various blood disorders. With that said, it is my pleasure to welcome Dr. Chonat. Thank you so much for joining us.
Thank you for having me and for a kind introduction. I want to thank AMDS for helping the patients' families and also bringing together community. So I've been invited here to talk about pediatric PNH, about diagnosis and management. As mentioned earlier, I'm a faculty in pediatric hematology at the Aflac Cancer Blood Disorder Center at Children's Healthcare of Atlanta and Emory University School of Medicine. These are my disclosures. I sit on the advisory board as also as a consultant for several companies, which includes some of them who have drugs related to complement therapeutics. And I'm going to get started with the talk on pediatric PNH. I like to always start with some about the history of PNH. One of the first reported cases of PNH was actually in 1882, as shown here. And which was described by Dr. Struberg about a patient and a group of patients later on presenting with paroxysmal nocturnal hemoglobinuria. But going backwards, prior to this report, there seems to be about 4 case reports going as far back as 1793, which have described patients who likely had PNH. So it's been there for a while, and we have certainly known for this for a while. So what's in the name? And some of you have already heard this before, but the PNH is an acronym for paroxysmal nocturnal hemoglobinuria. Paroxysmal is something which occurs suddenly or in an irregular or intermittent fashion. Nocturnal at night, and hemoglobinuria when there is hemoglobin, which is inside the red blood cell. When that red blood cell breaks down, the hemoglobin gets released into the blood and later on into the urine, which gives rise to this dark urine. Now, it's important to remember that this name can be misleading because not all of these features are seen in all the individuals. Additionally, not everyone will have dark urine. Now, the incidence, or how many new cases do we see in patients with PNH. This is in general is about 1 to 2 patients seem to get diagnosed per million individuals worldwide. The prevalence in the United States is about 5,000 to 6,000, and every year or so, close to 500 new cases gets diagnosed annually. Now, it's important to remember that many of these data are from registry or the International PNH Registry, so there are some limitations to these data. Of these patient groups, the most common age group that gets presented with PNH are about between 30 and 59 years of age. A quarter of these patients who get diagnosed are less than 30 years of age. And if you look at the patients with or children with pediatric children with PNH, they only account for about 10% up to 14% of all the patients with PNH. So it's still a very rare disease in this age group. The most important thing to remember is that no one is born with PNH. What we call as it happens later on in life, what we call as an acquired change or a somatic mutation. So this seems to occur in a gene which is called PIGA gene, and this gene is actually essential for production of these tox or these kind of stick-like proteins which actually help anchor these shields. Now, these red blood cells, when they lack these PIGA gene, there is lack of these what's called as anchor proteins, because they anchor these what's called as shields. So these shields help protect these red cells from complement damage. So this is a healthy red blood cell with shields present to help them protect against complement damage. This is a red blood cell in a patient with PNH where they have had the lack of these shields. They're so susceptible for breakdown of hemolysis. And we'll talk about this in the next few slides. So what is the underlying mechanism, or what leads to PNH? So I've shown here is a bone, and inside is a bone marrow. And as you can see here are these stem cells. So these stem cells are made inside the bone marrow, and they mature to any kind of blood cell. Okay, it can be red cells, white blood cells, platelets, and other types of white blood cells. Now, I've also shown is a PNH stem cell, and that occurs when there is a gene defect, as we discussed earlier, the PIGA gene defect. So this abnormal stem cell makes copies of itself, what we call as clones. And you might have heard the clones because your doctor may actually want to estimate the amount of clones or the percentage of the PNH clones. So these stem cells, as they multiply, they become clones. And finally, they mature to become red blood cells that have the mutant PIGA, or they're called PNH red blood cells. But it's important to note that you also tend to have formation of not just red blood cells, but also white blood cells and platelets, which can be division of with the PIGA or PIGA mutant platelets and white blood cells. And this is important for diagnostic purposes, which we will I'll try to highlight it in the next few slides. Over the next few slides, I will try to highlight some of the differences that we know from the minimal amount of data that we know in children, and I'll try to highlight what they may be different between children and adults. So in children, from what we know is that they tend to have a smaller PNH clone size, or the amount of these clones which are present in the bone marrow or in the peripheral blood, because the testing is typically done using a blood sample taken from the arm. And children tend to have a smaller PNH clone size. Now, this genetic defect that we discussed earlier alone is not sufficient to cause PNH. And we know now there's several internal as well as external factors which seem to drive this expansion of these PNH clones to result in PNH red blood cells. So some of these factors I've listed here are aplastic anemia, which as some of you may know, is that when there is a reduced number of cells within the bone marrow, and this can co-occur in PNH. The other conditions which also seem to drive or weaken the bone marrow are bone marrow disease and other various genetic factors. So the signs of this bone marrow defect that we'll discuss later are low red blood cell count, or low white blood cell count, and also low platelets. Now, shifting gears a little bit, because, and then hopefully we can put them together, is the complement system. So what is the complement system? So this is I've shown as a blood cell or a blood vessel, I'm sorry, and I've shown various blood cells inside the blood vessel. So we have red blood cells which carry hemoglobin and also oxygen. These are various kinds of white blood cells, and also shown some smaller platelets. And platelets help to make sure we don't bleed or bruise easily, and white blood cells help to fight infection. So what are complement? Complement are these small little proteins that I've shown in blue, about 50 proteins in the blood. And they're called complements because it complements the function of the white blood cell, meaning that they help to fight infection alongside the white blood cells. So we all have complement proteins, and we are born with complement proteins, and they're always there floating around in the bloodstream. So they're looking around for any bugs that you may get. If you have a scratch in your foot, if there's some bacteria getting into the bloodstream, these complements right there go in, they take care of it. And you may not even notice anything. You may not have any fever or swelling or redness of your foot or a great toe, but these complement actually doing this all the time. So as you can imagine, whenever there's a bacteria getting into the bloodstream, as the white cells and the complements are trying to fight, what complement does is that one of the end product of this complement reaction is this forming this little big molecule called MAC. And so this particular molecule actually tries to go and drill holes into this bacteria, and this bacteria is killed. While it does that, it does not recognize, oh, are these bacteria or the normal red blood cells? So these are healthy red blood cells. And as I mentioned earlier, this is the use of these shield-like proteins because it's shielding against this complement, so the red blood cells are not broken down. So these shields help the healthy red cells from complement-mediated hemolysis. Hemolysis is red blood cell breakdown. Now, PNH red cells lack those protective shields, hence they break down, and as they break down, they release hemoglobin. And this hemoglobin is what goes down to the urine to give the darkness of the urine. So this, I hope, kind of brings you together about the PNH red cells and the complement as to how it actually ends up leading to these symptoms that we're going to discuss in the next few seconds in specifically seen in PNH. Number one is hemolysis. So we talked about the breakdown of red blood cell. So when the red cell breaks down, as mentioned earlier, the hemoglobin gets released, and along with hemoglobin are these oxygen around. So whenever there is lack of hemoglobin, there's less oxygen delivery, or the oxygen is not really taken around the body very much. So people complain of symptoms of anemia. And oftentimes one of the top two symptoms of fatigue or tiredness. Headache is another common feature, especially when someone is anemic. People may find it really hard to do the day-to-day activities, and they may even complain of trouble breathing, especially when they're doing strenuous exercises, or maybe as simple as climbing up and down the stairs. And they may complain of difficulty breathing or even as chest pain at times. We talked about the presence of dark urine because this hemoglobin is getting into the urine and turning it dark. What also happens is that we have a lot of these smooth muscles, or muscles inside our windpipe, in the heart, in our abdomen, and those muscles we call as smooth muscles, and they are usually very calm and relaxed because they have this nitric oxide, which helps to remain them relaxed. Now, when there's too much hemoglobin that's getting spilled into the bloodstream, it actually starts to scavenge some of this nitric oxide. So when it takes away some of the nitric oxide, these muscles actually are less relaxed, and that explains why some individuals actually complain of chest pain or painful swallowing, or sometimes they talk about sore throat or even back pain. The second important symptom that is very important that we highlight a lot with PNH is the blood clot. So blood clot is whenever there is formation of a bunch of red blood cells various other proteins, resulting in this formation of a clot which completely occludes the vein. Most of these blood clots seen in PNH occurs within the veins. Very few occurs in the arteries. Interestingly, you might have heard about blood clot or thrombosis occurring in the arm or leg. But interestingly, in those with PNH, we tend to see the blood clots occurring in unusual sites. One of the most common ones that we talk about a lot are called a Budd-Chiari syndrome. It's essentially a blood clot which occurs in hepatic vein. It's one of the large veins which leaves the liver. It can also occur in the lung, resulting in pulmonary embolism or PE. It can also occur in the brain, in the skin, and of course in the limbs as well. The third important symptom is that patients with PNH may present, which may not be, it's not directly related to the PNH, but as we discussed earlier, these patients with PNH, they can have a bone marrow dysfunction. So whenever they have a bone marrow dysfunction, they make less of those stem cells and they make less of those mature blood cells, as we discussed. So they have less red blood cells, they have less hemoglobin. So again, they get anemic. They could have symptoms of anemia. Number two is bruising or bleeding. Platelets are those cells which make sure we don't bleed or bruise easily, so they can present with symptoms of that. Or they could present with symptoms of low white blood cell count, which could be infections. Your doctor might actually very frequently look for these symptoms and also look at various tests that we discuss in the next slide, looking for some of these bone marrow dysfunction. Now, what we have seen, us and also others which have published, that children tend to have slightly less hemolysis compared to adult patients, and they may have a slightly lower risk of blood clots. We do not know exactly why, but generally the children may not have other morbidity that some of the adults may encounter before they are diagnosed with PNH. And also we have noticed that children tend to have slightly fewer white blood cells, and which we will explain to why that may be the case. So how is PNH diagnosed? So diagnosing PNH has actually become fairly straightforward because we can easily detect the PNH blood cells by a special technique of flow cytometry. Essentially, they stain the blood cells with various different colors, and they can actually be able to see how much of them are present. So most importantly, we will not only look for PNH red cells, we also look for those PNH white blood cells, because some of the red blood cells are broken down. So we need to establish it, appropriately diagnosing it using those PNH white blood cells. The second thing that we commonly do is what's called as a complete blood count. And we do this to look for what is the hemoglobin. Are they anemic? Do they have low platelet count? Do they have low white blood cell count? Are they leukopenic, or are they neutropenic, some of the different types of white blood cells? We also look for evidence of hemolysis. Now, hemolysis is breakdown of red blood cells, as mentioned earlier. So these are some of the testing that's routinely done. Are they jaundiced? Because one of the byproducts of this hemoglobin is bilirubin, which gives that yellowness to the eyes. We look for LDH, which some of you may be very familiar with, that we actually follow whenever you go visit the doctor during routine follow-up if you have been diagnosed with PNH. And that's an enzyme which gets released when the red cells are being broken down. We look at urine to see how much of hemoglobin is being spilled in the urine. Reticulocyte is a marker of bone marrow function, meaning that it's a baby red cell or immature red blood cell. So it gives us an idea in terms of how much is the bone marrow working hard, and two, is it because are these blood cells getting broken down inside the blood vessel? The fourth thing that we look for in majority of cases, are there any evidence of bone marrow failure or dysfunction? Now, obviously, some of these blood cells can help us identify if the cell numbers are lower, but measuring this a little bit more appropriately within the bone marrow gives us more of an objective way of identifying aplastic anemia or other bone marrow dysfunction. So how do children present with PNH? So we like to, when someone gets diagnosed with PNH, or once we know for PNH for sure, we'd like to put them in two major buckets, is what I call it. Now, there is a group which I've not mentioned here, it's called subclinical PNH. And that's called subclinical because they typically have very small, those PNH clones we talked about, and often way less than 10%. And they typically do not cause any clinical problems. And additionally, they have a normal bone marrow exam. But most importantly, these patients with subclinical PNH continue to be followed or monitored closely. So turning to our focus on the two major ways that children with PNH present. One is aplastic anemia PNH. Now, aplastic anemia PNH is a group of children where they have PNH, but they also have aplastic anemia, meaning they have less number of cells in the bone marrow. So as the name suggests, patients have significant clinical and laboratory evidence of bone marrow failure. And they may not have that much hemolysis or breakdown of red blood cells. And the amount of PNH clones that we talked about, the doctors often measure this on a routine basis, are usually slightly lower than the other category to the right, which is the classical or hemolytic PNH. So this classical or hemolytic PNH is a group where they tend to have a breakdown of red blood cells and symptoms secondary to that. So they could have dark urine. They may have a very high LDH, which is the enzyme which gets released during the breakdown of red blood cells. And additionally, these patients, when we look at the bone marrow, they may have a nearly normal looking bone marrow. And these patients, as mentioned earlier, have a large size of the PNH clones, which could kind of explain of this hemolytic type. Now, this is the aplastic anemia PNH is slightly more commonly seen in pediatric patients than the classical PNH. And this could explain why patients or children have a slightly lower amount of hemolysis, but they also have a lower number of fewer white blood cells and platelets and red blood cells, is because they have more of this aplastic anemia PNH. So once we diagnose someone with PNH and once we arrive at a diagnosis, I think it's important to look for this aplastic anemia. And then once you classify them to one of these two major types, helps in coming up with a plan as to how we're going to manage this child or young individual. So as mentioned earlier, the presence of PNH clones in aplastic anemia or bone marrow failure may suggest that the patient may require immune suppressive therapy or even maybe a candidate for bone marrow failure. In the interest of this talk, which is primarily geared towards PNH and its management, I'm going to focus on the use of specific complement inhibition in PNH. Additionally, I'm going to discuss the importance of supportive care in these patients. And the importance of supportive care more so is important in the classical or hemolytic PNH, but also very much in the aplastic type. So supportive care is a term that we use, especially when, in addition to using complement inhibition for PNH, what else can we do to support them? And I decided to discuss this first because oftentimes these things are very important not to forget, because these are the ones that we continue to monitor on a regular basis. So we look to see, are they requiring transfusions? They may require transfusions till they get onto some complement treatment, but they may also sometimes require transfusions in spite of being on the specific treatment. Sometimes they may require iron therapy, so we have to monitor their iron levels. We also routinely look at their vitamin B12 levels. Rarely some of these patients require other treatments such as erythropoietin. Now, erythropoietin is a hormone which helps to boost the production of red blood cells only. And additionally, sometimes we also put them on folic acid. Folic acid is one of the building blocks of red blood cells. So whenever someone is trying to make too many red blood cells, we want to optimize the conditions within the bone marrow to help make more red blood cells. Another important aspect of supportive care is ensuring that if a blood clot is detected either before diagnosis of PNH or after diagnosis of PNH, is that we may manage these blood clots using a blood thinner or anticoagulation. The various different medications that can be used, but oftentimes we use this along with the complement therapy that we'll discuss the next few slides. And sometimes some of these anticoagulation may be for very long term. So now we'll delve into the complement system. We talked about what are these complements. They help to fight infections. So I've shown here of these various number of proteins that help act in a very close, concerted manner to help fight infections. As mentioned earlier, one thing they end up forming is this small little molecule called small little molecule that I've shown here is called the MAC complex. As I mentioned earlier, if the PNH red cells, when they lack the protective shields, it sits on the red cells, breaks them apart. So what was devised on the first medication which came in is called eculizumab. Now we all know it's a Soliris. Now it's a medicine that actually blocks C5. Now C5 is a protein as shown here. So when you block C5, you're not going to help form this at all. So the C5b9 is never formed, so red cells are not continually attacked by this complement, and hence the red cells are spared from breakdown. Now it was approved for adults in 2007, and as shown here that it blocks complement C5. It is given intravenously every 2 weeks. And patients, as you can imagine, that if they are blocked here, they could accumulate the C3 on the red blood cells. So some of these patients on this therapy may also continue to have breakdown of red blood cells. In fact, it doesn't happen within the blood vessel. It actually happens in the spleen, what we call as extravascular hemolysis. And there is actually a lot of treatments that are being looked into for this particular condition, along with eculizumab in adult patients. The clinical trials are actually ongoing. And in fact, some are completed. The second drug, secondary to eculizumab, is what we call as a longer-acting eculizumab or ravulizumab. The brand name is Ultomiris in the United States. It was approved for adults with PNH in 2018. So this also blocks C5, but it is designed such a way that it actually lasts for a really long time. Typically, it's used every 8 weeks, but for those younger children of a smaller body weight, you may have to use every 4 weeks. And so these two were the first two agents to be approved for adults with PNH. Now, so far we have only one FDA-approved medication for children and adolescents with PNH, which is ravulizumab or Ultomiris. And this was a study which is actually ongoing, where they looked at how well it works in children. So what we call as a pharmacokinetic and dynamic in terms of how well the drug goes through the body and gets metabolized. We also looked at how well it actually blocks the complement and see if they actually become transfusion independent, what's called as efficacy. And they also looked at the safety of this drug. And this study is ongoing. It actually has 13 patients. It was conducted at 9 sites or across 6 countries. And after about 26 weeks, the data was actually presented by us mid of last year. 5 of these 13 patients were never been treated before, what we call as a naive or naive to any complement inhibitor therapy. And of these 3 of them, or 60% of them, actually avoided a blood transfusion. And 8 of the 13 patients who were already on eculizumab treatment, they were switched to this ravulizumab treatment. They have continued to remain well and have continued to avoid a blood transfusion, meaning that this drug is efficacious in that particular group of patients. I've listed some of the common side effects that was reported and during that report last year after the 26 weeks. Additionally, they also looked at the fatigue score or the quality of life score, and patients who are on this drug, ravulizumab, reported slightly improved quality of life. And this data helped approval of this drug for children with PNH in June of last year. Now, I do want to highlight, in addition to the C5 inhibitor, the two ones I talked about, there's one of the inhibitor, what's called as, which targets C3. So C5 is down here. Yeah, there are other drugs of which one of the main ones is C3. It's fairly higher up. The ones which are called pegcetacoplan. This is actually FDA approved for adults with PNH. It was approved last year. It's called Empaveli here in the United States. It's given as a subcutaneous infusion. It's actually a drug which can be given in the pump. It can be actually done at home by the patients. They stick a very tiny needle under the skin, and the pump delivers this medicine over a few minutes, and then they can take away the needle with themselves. So this helps to be given at home. Like I mentioned, it's approved for adults, and clinical trials are currently ongoing in children to see how well it works in children, if it continues to be efficacious in children, and also looking at the safety of this drug in children and adolescents over 12 years of age. The other drug that I listed here, the only one which actually been listed within the clinical trials, clinicaltrials.gov as it's for children with PNH is called crovalimab, which is also a drug which targets C5, which is right here, which is also given subcutaneously, so it can be done once weekly at home. One thing I did not mention on the previous slide is that ravulizumab, the longer-acting drug. Nowadays, some of these drugs can also be administered at home by the infusion team, but still require intravenous access. But there are other modes of delivery of these drugs are being looked into, including subcutaneous. Okay, go to the next slide. So I'm not going to go through the entire slide here. So what I've listed here are these clinical trials for children with PNH. I just briefly discussed the pegcetacoplan, which is a C3 inhibitor, which is ongoing for children 12 to 18 years of age. The one which is FDA approved, the study is not fully complete yet, but it'll be closed very soon. The other three clinical trials I've listed here are of the same drug called crovalimab, which is a C5 inhibitor. And on the website, it does lists of including children 12 years and older. And they're comparing this drug against eculizumab, which we discussed earlier, or just by itself for those who have never been on any complement inhibitor. So this is really an exciting time for PNS in general, but also in children, because many of these studies are actually being investigated in children, because many of the drugs which are actually used in children might not actually have an FDA approval because they're not really completely studied. So this is actually something that has really moving this field forward. Now, this is a slide about the precautions while on complement blockade. I cannot emphasize it enough, that these drugs, as mentioned earlier, as it helps to fight infection, the complement, if you block the complement, there's going to be a risk of infection, of which the most important risk of infection is a brain infection called meningitis. So how do we help to prevent it? There are certain vaccines which are actually routinely given for any child in this country. But if they are going to get this medicine, we have to give this vaccines early on. Ideally, you want to vaccinate 2 weeks before we give the first dose. And the two types of meningitis vaccines called ACWY and B, they're different names in the United States. And I usually refer to the CDC vaccine recommendations because there are a series of vaccines that have to be given, and typically there's a booster every 5 years. And many physicians, including myself, do recommend prophylaxis. So we, in addition to being vaccinated, we actually recommend penicillin to be taken daily, especially in some patients who are at a high risk of getting this meningitis. In addition, we provide anticipatory advice to ensure that the patients and families seek emergency care, especially if the individual who's on these medications experience any of these which I've listed here, such as fever, headache, rash, chills, muscle pain, or other illnesses. The idea is that the earlier you can reach the hospital, you can actually they do some blood work, and we can give a dose of intravenous antibiotic. Many of these providers, including myself and also these drug companies, ensures that a safety card is given to this family member. So they carry that safety card all times so that they can take it to the emergency department, so that the physician or the provider of the emergency department can identify this as a high-risk patient. They have to administer this antibiotics early on. In addition to the vaccines to protect against meningitis, vaccines against Streptococcus pneumoniae and Haemophilus influenza type B or Hib are again routinely given for children, and we want to ensure that the children are in fact vaccinated against these infections. So it's important that we have come a long way being able to provide specific medications for management of PNH in adults and also in children. But I think it's important that PNH can still be very burdensome, especially because some types require long-term complement treatment or complement inhibitor treatment, and also supportive therapy such as transfusions and antibiotics, etc. So it's important that we pay attention to it. There's not a lot of data in children. So one of the things that we have to work on as a community to be able to ensure that we actually get some more information, especially specifically to the children. So it's important that these children or young adults are at a risk of blood clot or risk of organ damage, such as kidney diseases, so lifelong. So it's important to recognize that. Some of these children who come and see me, they do miss school every time they have to come to the hospital. And some of the parents or family members have to miss work and so on to be able to actually bring them to the appointments and infusions. So there's actually a lot of burden, not just on the patient, but also on the rest of the family members. As mentioned earlier, some of the registry data have shown that patients with PNH have reported a fatigue score, a quality of life score being similar to patients with cancer. So it's important to sometimes recognize that these patients might not actually have a malignant disease, but in spite of having something not cancer, they could still have a significant burden of being diagnosed with PNH. While treatments such as we discussed earlier has shown to improve quality of life, but there's still a long way that we have to go in ensuring this, that we can improve the quality of life in these patients. So with this, I want to summarize by saying that it's still very important that any of these at-risk patients are discussed and diagnosed early. Nowadays, the rapid diagnosis is possible in most places, so it's important to appropriately diagnose. And there are a lot of benefits of being part of clinical trials. So looking for clinical trials, especially if you get diagnosed with PNH, would be help, because you may be able to get to a bigger center and being managed by an expert in PNH. Additionally, you may be able to get hold of a cutting-edge therapy because there's newer and newer treatment options are being available for those with PNH. Not everyone will be eligible for clinical trials, and there's always risks involved. So it's something that you should discuss with the provider who's offering you the clinical trial. We're getting better in terms of improving the delivery of these drugs. As mentioned earlier, this can be given at home, and they're getting longer acting, such as some of these medications, which can last for 4 to 8 weeks. So certainly with this, as a remarkable advancements in being able to deliver these medications with minimal interruption in day-to-day life. But it's important that we continue to monitor these patients closely for supportive care, especially in children. We have to ensure their growth are adequately met, and their growth milestones are also adequately met. These patients are recommended to see the doctors because the doctors may want to monitor the disease, but also some of these patients may need to monitor their bone marrow function on a regular basis. We also monitor many of the nutrition and the vitamin levels, and also some of the bone function in some of these patients who may require long-term blood thinner medications. As mentioned earlier, I cannot emphasize the importance of quality of life that should go hand in hand with many of these clinical trials. And more importantly, I want to finish off this talk of the importance of being part of a bigger registry, because these are very rare diseases, and even in children with PNH, they're even rare. A global PNH patient registry was kind of initiated not long ago, and this is actually run by the National Organization for Rare Disorders. And you can actually get to this website either by using this web address that I've quoted at the top, or you can go through the AAMDS website. I think when you go now, this is the first thing which comes up. And this is actually for the patients. We want patients and families to be able to put in the information about how are they feeling, and that's going to help us understand the actual needs that the patients and families may have. And it also helps us researchers to be able to collect data from a larger number of individuals from different parts of the world, and obviously helps us to understand. So you will be contributing to the better treatment options, and also in general, improving the knowledge and treatment of PNH. Now, with this, I'd like to thank patients and families having taken care of children and adolescents and also young adults with PNH for just over a decade. I've learned the most of this actually from patients and families. And also, it's a rare disease, so hence we need a lot of other care providers who actually helps to make this happen. Additionally, my colleagues and mentors who I've often reach out to, especially adult colleagues who actually see 10 times the number of patients that I may have with PNH. I've also listed my funding sources who actually help me continue my research and also my being able to see patients and take care of them. With this, I'll stop here, and I'm excited to take questions.
Thank you so much. We have a few questions. Our first question is, my son is going to be 18 in just a few weeks, was recently diagnosed with PNH, and we know that there are 3 of the FDA approved treatments. How does one decide which treatment is appropriate, and how does one decide whether transplant would be the best option?
Yeah, it's a very important question. So the first thing is that PNH, we have to see if there is any bone marrow dysfunction. Aplastic anemia, bone marrow failure are the times that we actually offer bone marrow transplant as one of the treatment options. PNH by itself, without any bone marrow dysfunction, is nowadays not a direct indication for transplant. So I do not know the specific condition, so I'm going to answer in a general way that's important to first of all find out if there is a bone marrow dysfunction. Number 2, in terms of choosing if the PNH is symptomatic enough, meaning that they're breaking down of red blood cells, and there is anemia which is directly related to the PNH, then choosing any of these drugs would to some extent depend on is it FDA approved? I'm assuming since they're not 18 yet. 2, it depends upon whether this is something that can be done as a long-term, because I mentioned ravulizumab is available for every 8 weeks. That would be the preferable over eculizumab at this point if you have to choose someone which is FDA approved. But certainly you're getting closer to the age group of 18, and that's a discussion to have with your provider to see is there something that you want to do once every 8 weeks, or something that you want to do at home every 2 weeks, which is be a subcutaneous infusion. It's important that since we're having more and more medications coming through, it's not the physician or the provider telling you what is the right thing, but it's actually a combined discussion and a decision that's taken as to what's best for that particular patient.
Our next question comes from a parent whose child was diagnosed with aplastic anemia, and the child underwent immunosuppressive therapy and has been doing great for the last 5 years. They'd like to know how often should a child be tested for PNH, And is this lifelong watching for?
Yeah, it's actually excellent question. When someone is getting diagnosed with aplastic anemia, bone marrow failure, we actually recommend looking for PNH clone actually at diagnosis as early as possible. But in this case, after treatment, we recommend to continue monitoring for PNH at least every 6 to 12 months. And while patients with aplastic anemia are going to get monitored typically by either a bone marrow transplant doctor or a hematologist, depending upon the circumstances, they may be able to very easily monitor for PNH every time you go in.
This question is from a parent whose child had aplastic anemia, no PNH was diagnosed, and they had a successful transplant. They'd like to know, do they still need to be monitored for PNH?
Yeah, it's a great question. So this is different to the previous one where they had immune suppressive therapy. So after transplant, you would effectively would have cured a PNH if you did have PNH at the beginning. So as long as the transplant is working okay with regards to the chimerism as to how much is the donor versus you, I don't feel strongly that a long-term monitoring of a PNH clone is necessary.
Does the onset of puberty affect PNH as a disease? And does it also affect the treatment options? As in, I'm assuming they're speaking of if the child were to use Ultramarys as a treatment, does the treatment need to be adjusted due to the fact of onset of puberty?
Yeah, no, great question. So it's very important to understand that, especially in any childhood disease, but also in PNH, there's going to be changes with slight changes in various parameters of hemoglobin and red blood cell as they age. Additionally, during the adolescent period, there may be an increased requirement for many different reasons. In this case, I'm not sure if it's a male or female, so there could be additional issues such as if it's a female, they could start having periods, so there could be additional risk of blood loss and iron deficiency. So monitoring all those is very important. So as I mentioned about supportive care. With regards to specific management of PNH, there shouldn't be any difference in terms of being closer to the puberty. In fact, none of these medications should make any difference whether you're before puberty or after puberty or going through puberty. They should all work the same way, except the fact it's important that some of these newer medications are usually weight-based. It's important to monitor the weight gain appropriately when you're dosing or when you're picking up the right dose for these individuals.
Next question is, when are contact sports okay for children with PNH? Specifically, my son would like to play football.
Yeah, it's a great question. Not exactly knowing the blood numbers. The most important thing to remember is that the platelet count. PNH by itself typically do not cause lower platelet count unless they may have a blood clot, which may result in a slightly lower platelet count, or some individuals may have some amount of bone marrow dysfunction, which may have a lower platelet count. So the lower platelet count, because as mentioned earlier, platelets are those sticky cells to make sure we don't bleed or bruise easily. So that would be a major decider of contact sports. It's not the PNH diagnosis per se. If the person has PNH and as indication for an anti-complement therapy, and the patient has never had a blood clot, the risk of blood clot is very small. So any contact sport should not necessarily increase the risk of blood clot. So the contact sport allowance should be purely based on are the patient's high risk of bleeding. So I would specifically discuss that with your doctor in terms of what are your risks of bleeding. But otherwise, I do not see any major restrictions to playing contact sports just with PNH alone with normal blood cells.
With the COVID vaccine, is there an increased risk of hemolysis for PNH patients?
Sorry, I missed the first word. Do you say COVID
Oh,
vaccine?
sorry. With the COVID-19 vaccine, is there an increased risk of hemolysis for PNH patients?
Yeah, very important question. The short answer is yes. We have also experienced this in our patients, and others have also reported. So it's definitely seen in children, adolescents, and older adults that there is a slightly increased risk of hemolysis, both with vaccine as well as infection. But it's important that the benefits of COVID vaccine far outweighs any of the risks with infection. So hence, we strongly recommend vaccine. We recommend vaccine to be given slightly closer to the time point after you've received your complement inhibitor, if you're due to get one. And if you do get vaccine, if there's any concerns of hemolysis, such as tiredness, dark urine, jaundice, or any of those, then to seek or to inform your doctor so they can check the blood levels to see if you are indeed having a breakthrough hemolysis due to vaccine.
Our last question is, my daughter is getting ready to go off to college in the fall, and probably will have to at some point go seek a doctor's advice. How, whether it's going to the clinic on campus or so on, how do we explain what is PNH, as most medical professionals probably have not even heard of PNH? Is there a simple explanation that we can give?
Excellent. I completely agree with you that PNH being a rare disease, many of them might not have even seen a case of PNH and gone through the entire medical career. I'll try to talk to my patients and also in terms of what to tell their family members and other physicians. I always encourage them to actually have a card if they're on complement inhibition and also PNH, so that they can actually give something to them so they can read it. So many of the times, actually, if they're able to read it or look at it, makes a huge difference. But if you have to really explain it verbally, I recommend saying on the lines of that this is a serious blood disease which results in breakdown of red blood cells uncontrollably unless treated. So the idea would be to actually increase awareness and help them understand that this disease is something that can be quite dangerous if not properly taken care of. And additionally, I would encourage that if you're actually moving away to a different state, is to have the discussion with the current medical provider to be able to come up with a very clear plan and discuss in person or through emails with the new provider elsewhere, maybe even an adult provider, so that records are appropriately transferred. Additionally, it is nothing more exciting than someone who's going to college, but at the same time to be able to empower the patient or the young adult to know exactly what the disease is, so they can actually be able to educate others. I've kind of touched upon quite a few things, but I think knowing about the disease is best, because then you can actually explain this best to others.
Thank you so much, Dr. Chonat, for spending your time and your expertise and sharing all this wonderful information with us today. Very much appreciated. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us anytime in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or you can submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thank you again.
Thank you.